Welcome back to the deep dive. Today we are shifting gears a little bit. We're moving away from general interest and diving straight into, well, the deep end of high-stakes academic preparation. We are officially going into exam mode.
That's right. We aren't just exploring a topic today. We're trying to simulate a high-level review session, one that's specifically tailored for a postgraduate MD anesthesiology student.
So I want you, the listener, to just visualize the scene for a second. You are weeks away from your finals. Maybe it's the Gujarat University MD exams, maybe the DNB, or even the FRCA. You've got those massive textbooks stacked up on your desk.
Oh, I remember that feeling.
Right. You've got Miller's Anesthesia, Guyton and Hall for the core physiology, B.D. Choreja for the anatomy, and of course, Stolting for the pharmacology.
The Tower of Babel of medical knowledge, as I like to call it. And looming over that whole stack is the dread of that one big question, the 20-mark theory question.
Exactly. And the question reads, describe the anatomy, physiology, and functions of the liver with interpretation of liver function tests and anesthetic implications.
It is a classic, a total classic. And honestly, it's a beast of a question. It covers everything from, basic structure to really complex pharmacokinetics. Examiners absolutely love it because it tests integration. If you can answer this properly, it shows you understand how the body works as a system.
So our mission today is to take that mountain of information from all those books and distill it, turn it into a structured spoken answer that you can use in a theory exam, or maybe even more importantly, in a grueling viva voce. We are going to turn the pages of the textbooks into a conversation.
Precisely. Because for an anesthetist, the liver isn't just some organ sitting in the abdomen. It is the metabolic clearinghouse. It's the pharmacokinetic engine of the entire body. If the liver goes down, your whole drug management plan goes out the window.
Okay, so let's start with part A, the introduction. How do we frame this for an examiner? How do you open that answer?
You need to start with the clinical weight of the organ. You'd say something like, the liver is the largest solid organ in the body, and it's absolutely essential for homeostasis. In anesthesia and critical care, its assessment is crucial because it dictates drug metabolism, it dictates your coagulation status, and glucose regulation.
And you mentioned exam patterns earlier.
Right. So in the exam, this topic really comes at you in three ways. First, there's the long note, that's the 20 marker we just mentioned. Second, you'll see short notes on bits and pieces of it, like hepatic blood flow regulation or anesthetic implications of obstructive jaundice.
Okay, that makes sense.
And third, and this is the one to watch out for, is the Viva trap.
The Viva trap.
Yes. Examiners love asking about the difference between liver function and liver damage, or asking you to explain the mechanism of the hepatic arterial buffer response.
Yeah.
If you stumble there, the whole Viva can go downhill very, very fast.
All right, consider us warned. Let's dive into part B then, anatomy of the liver. B.D. Choreja is kind of the Bible here for the gross anatomy, right?
It is. And the gross anatomy is very high yield. We know it occupies the right hypochondrium, and it extends over into the epigastrium. It's heavy, weighs about 1,500 grams in an adult.
But for an anesthetist, just saying upper right abdomen isn't really specific enough. We need surface landmarks.
Correct. Imagine you're doing a procedure or assessing a trauma patient. The upper border of the liver is usually at the level of the fifth intercostal space. The lower border roughly follows the transpyloric plane. So if you can palpate the liver edge significantly below the costal margin, you're either dealing with hepatomegaly or, maybe a hyperinflated chest that's pushing it down.
Okay, and the liver has 5 surfaces: anterior, posterior, superior, inferior, and right. But there's one specific area on the posterior surface that is an absolute favorite for examiners: the bare area.
The bare area is critical. On the posterior surface, there's this triangular area that is not covered by the peritoneum. It's in direct contact with the diaphragm.
Why does an examiner care so much about a patch of bare tissue? What's the significance?
Because it represents a highway for pathology. Since there's no peritoneum to act as a barrier, infections, like a liver abscess or even malignancies, can spread directly from the liver through the diaphragm and into the thoracic cavity.
So it completely bypasses the peritoneal cavity.
It bypasses it entirely. It's a direct link, a back door, between the abdomen and the chest.
That's a brilliant Viva point. Okay, now let's flip the liver over and look at the underside, the porta hepatis.
The hilum of the liver. You'll almost certainly be asked about the arrangement of structures there. The mnemonic to remember is VAD. VAD. Let's unpack that.
So from posterior to anterior, it's portal vein, hepatic artery, and hepatic duct, VAD. It's crucial for surgeons during dissection, obviously, but also for us to understand the relationships if there's, say, compression from a tumor.
Okay, let's talk about lobes. We learn in basic anatomy that there's a right lobe and a left lobe, and they're divided by the falciform ligament. Simple enough. That is the anatomical description. But if you were sitting for a postgraduate exam, that is just not enough. That's the morphological division. You absolutely need to talk about the functional anatomy, the Couinaud segments.
Couinaud, that's Couinaud.
Correct. This classification divides the liver into 8 independent segments, numbered 1 to 8, and it's all based on the vascular supply and the biliary drainage. Each segment has its own inflow and its own outflow. This is the basis of modern liver surgery.
So it allows surgeons to do things like hemihepatectomies.
Semihepatectomies, segmentectomies, all without sacrificing the whole organ. It's a surgical roadmap.
And from an anesthetic perspective, why does this surgical detail matter to us?
Because of the exposure.
Yeah.
To get to some of those segments, especially the posterior ones, the surgeon has to use really heavy retraction. That retraction in the upper abdomen compresses the liver tissue, and it can reduce hepatic blood flow by up to 60%.
60, as in 60.
Yes. You might be looking at your monitor thinking the mean arterial pressure is fine, everything looks stable, but the liver itself is suffering a significant local ischemia because of that retractor. It's a silent insult that you won't see on the monitor.
Wow. Okay, let's zoom in now. Microscopic anatomy. This is the exam core, as you called it. We have the lobule and the acinus. What's the difference?
Right. This is where you show you've read Miller and Guyton, not just the basic anatomy text. The classic description is the hepatic lobule. It's hexagonal in shape. It has a central vein sitting right in the middle and portal triads at the corners. Looks a bit like a honeycomb.
It's great for histology slides.
It is. It's beautiful for histology.
Yeah.
But it's terrible for physiology. It doesn't explain the oxygen gradients or the different metabolic zones. For that, you need to understand the liver acinus.
Okay, so explain the acinus.
Imagine 2 central veins and 2 portal triads. If you connect them, you get a kind of diamond shape. The blood supply comes from the center of that diamond, from the portal triad, and it flows outward toward the central veins at the tips of the diamond.
And this creates zones, right?
Exactly. The acinus is divided into 3 zones based on the distance from the blood supply. This is, and I can't stress this enough, the single most important concept for understanding liver injury.
Okay, so walk us through the zones. Zone 1.
Zone 1 is periportal. It surrounds the portal triad. It gets the first drink from the fire hose, you could say. It has the highest oxygen tension, the most nutrients.
So Zone 1 is the high-rent district.
It absolutely is. It handles all the energy-intensive tasks, oxidative metabolism, gluconeogenesis, urea synthesis. It's very resistant to hypoxia because it's closest to the blood supply.
Then you have Zone 2, the mid-zone, and finally Zone 3, the perivenous zone.
Right. And Zone 3 is at the end of the line. By the time the blood reaches Zone 3, it's pretty low in oxygen and nutrients.
Yeah.
This makes Zone 3 the site of things like anaerobic glycolysis and lipogenesis. But critically, Zone 3 is where the cytochrome P450 enzymes sit.
Ah, so Zone 3 handles all the drug metabolism.
Yes, and that combination, a low oxygen supply plus high metabolic activity for drugs, makes it incredibly vulnerable.
Vulnerable to what, specifically?
To shock and to toxicity. If a patient becomes hypotensive, Zone 3 is the first part of the liver to die. That is shock liver or ischemic hepatitis. It was always a Zone 3 necrosis. And also, toxic metabolites from drugs like paracetamol or acetaminophen, they accumulate right there.
So if I'm in the exam, explaining the acinus in Zones 1, 2, and 3 is going to get me more marks than just describing the hexagonal lobule.
Oh, much better. It shows a functional understanding, not just rote memorization of a shape.
Before we leave anatomy, we have to talk about the plumbing, the blood supply. You've listed this as absolutely essential.
Because it is. The liver has a dual blood supply. This is unique among major organs.
Right. Most organs just get an artery.
The liver is greedy. It gets the portal vein and the hepatic artery. Now, the numbers here are key for the exam. The portal vein provides about 70 to 75% of the total blood flow.
That's a massive amount of venous blood.
It is. It's coming from the entire gut, the spleen, the pancreas. It's incredibly nutrient-rich, but it's partially deoxygenated. The saturation is only around 85%. But despite that, because the volume is so huge, the portal vein still supplies about 50 to 60% of the liver's total oxygen needs.
And the hepatic artery.
That provides the other 25 to 30% of the flow. But because it's high pressure, fully saturated arterial blood, it supplies the remaining 40 to 50% of the oxygen.
And the total flow is around 1.5 liters per minute?
Roughly, yeah. About 25% of the resting cardiac output goes straight to the liver. That's huge.
Okay, now here's the concept that you said will get you the extra marks, the hepatic arterial buffer response, or HABR.
HABR. If you remember one physiological reflex from this, make this one. Here's the problem. The portal vein flow is passive. The liver can't really control it. It just depends on systemic blood pressure and splanchnic vascular resistance. So if your patient bleeds, portal flow drops.
So the liver is kind of at the mercy of the portal vein.
Generally, yes. So to compensate for that, the hepatic artery has to step up. The HABR is this elegant mechanism that ensures if portal blood flow decreases, the hepatic artery dilates to increase its own flow and maintain oxygenation.
What's the mechanism? How does the artery know that the portal flow has dropped?
It's believed to be the adenosine washout theory. So under normal flow, the portal blood constantly washes away locally produced adenosine. If that portal flow slows down, adenosine starts to accumulate around the hepatic arterioles. And adenosine is a potent vasodilator, so the artery opens up.
That is elegant. And anesthetic agents can mess with this.
They absolutely do. Halothane is the classic villain here. It causes vasoconstriction, and it actively inhibits this buffer response. That's one of the big reasons halothane is so bad for hepatic blood flow.
And the modern agents?
Isoflurane, sevoflurane, and desflurane act as vasodilators themselves, and they tend to preserve the HABR much, much better.
Okay, let's move to part C, physiology and functions. Guyton calls the liver the biochemical hub.
It really is a factory, an incredible factory. Let's break it down by metabolic function. First up, carbohydrates.
The glucose buffer function.
Exactly. The liver works tirelessly to maintain normal glycemia. When you eat, insulin drives glucose into the liver for storage as glycogen. We call that glycogenesis. When you're fasting, the liver breaks that glycogen down, glycogenolysis.
And what if the fasting continues for longer?
Like in our NPO patients, right? The liver then switches to gluconeogenesis. That's making new glucose from other sources, like amino acids and lactate.
So what is the anesthetic relevance of all this?
Well, if the liver fails, you lose that buffer entirely. These patients are incredibly prone to severe hypoglycemia during fasting because they have no glycogen stores and they can't make new glucose. And on the flip side, they get hyperglycemic after meals. You absolutely must monitor their blood sugar tightly.
What about protein metabolism?
The liver deaminates amino acids, which is part of breaking them down. This produces ammonia, which is highly toxic, especially to the brain. The liver then converts that ammonia into urea via the urea cycle, which is then safely excreted by the kidneys.
And if that fails?
Ammonia builds up, it crosses the blood-brain barrier and causes hepatic encephalopathy. That's why you see confusion and altered sensorium in patients with liver failure.
Then there's lipid metabolism.
A huge role there, too. Beta oxidation of fatty acids for energy, synthesis of cholesterol, phospholipids, and all the lipoproteins. It's central to lipid transport.
Let's talk about the synthetic functions. You've marked this as exam gold.
It is. This is what you really need to hammer home. The liver synthesizes almost everything floating around in the plasma. 90% of plasma proteins, including albumin. And critically for us, the coagulation factors.
All of them?
All of them, except for factor 8 and von Willebrand factor. Those are made by the endothelium. But factors 1, 2, V, 7, 9, X, XEX, 12, all of them come from the liver.
So in liver disease, you expect bleeding?
Yes, coagulopathy is a hallmark. Plus, you have hypoalbuminemia.
Why is low albumin a problem for the anesthetist, besides the obvious edema?
Drug binding, yeah. So many of our drugs, thiopentone, bupivacaine, benzodiazepines, are highly protein-bound, mostly to albumin. If albumin is low, the free fraction of the drug increases dramatically. A standard dose can suddenly lead to an overdose effect because there's so much more active, unbound drug floating around.
That segues perfectly into detoxification and biotransformation. This is the pharmacology focus.
We mentioned zone 3 earlier, and this is its time to shine. This is where most drug metabolism happens. We generally divide it into phase 1 and phase 2 reactions.
Can you break those down for us?
Sure. Phase I is modification, usually oxidation reduction or hydrolysis. This is primarily done by that family of enzymes called the cytochrome P450 system. The goal of phase 1 is to make the drug a little more polar, more reactive, to prepare it for the next step.
And phase 2?
Phase 2 is conjugation. The liver basically welds another molecule onto the drug-like glucuronic acid or a sulfate group. This makes the whole complex water-soluble so it can be excreted either in the bile or by the kidneys in urine.
Now, Stulting introduces a concept called the hepatic extraction ratio, or HER. This often confuses students.
It's a key concept for understanding drug clearance. HER describes the efficiency of the liver in removing a drug from the blood in a single pass. It's a number that ranges from 0 to 1.
And we have high HER drugs and low HER drugs.
Right. High extraction ratio drugs, think propofol, lidocaine, morphine, are cleared so efficiently that the liver removes almost all of it as it flows through. For these drugs, the limiting factor isn't the speed of the enzymes, it's how much blood you can get to the liver in the first place.
So these are flow dependent.
Exactly. If a patient is in shock and their cardiac output drops, the clearance of propofol also drops. The drug will last longer.
And low extraction ratio drugs.
So these are drugs like thiopentone, diazepam, rocuronium. Here, the HER is low. The enzymes work pretty slowly. Increasing blood flow doesn't really help much.
Right.
For these drugs, the limiting factor is the capacity of the enzymes themselves.
So these are capacity dependent.
Correct. So in severe liver disease like cirrhosis, where you've lost a lot of hepatocyte mass, these drugs can last forever because the enzyme capacity is just gone.
That is a crucial distinction. Flow dependent versus capacity dependent. Let's touch on bile.
The liver makes a lot of it, about 600 to 1,000 ml of bile a day. Its main job is to emulsify fats, which is absolutely critical for absorbing fat-soluble vitamins, especially vitamin K.
And no vitamin K means?
No production of clotting factors 2, 7, IX, and X. So you can see that even if the hepatocytes themselves are working fine, if you have a biliary obstruction, you will still get a coagulopathy.
And bilirubin, the source of jaundice.
Right. Hemor from old red blood cells breaks down to unconjugated bilirubin. This form is not water-soluble. It has to travel to the liver bound to albumin. The liver then conjugates it, making it water-soluble, and excretes it into the bile.
This process gives us the classic classification of jaundice.
Exactly. Prehepatic, like in hemolysis, hepatic, like in hepatitis or cirrhosis, and posthepatic, which is obstruction from a gallstone or a tumor.
Finally, before we hit the LFTs, tell me about the Kupffer cells.
They're part of the reticuloendothelial system. They're basically resident macrophages that line the liver sinusoids. They act as a critical filter for all the bacteria coming from the gut via the portal vein.
So they prevent systemic sepsis from gut bacteria?
That's their main job. In liver failure, this filter breaks down. And that's a big reason why patients with liver disease are so incredibly prone to sepsis and other systemic infections.
Okay, that was a whirlwind tour. Let's move to Part D, liver function tests. You mentioned earlier this whole term is a bit of a misnomer.
It really is. We call them LFTs, but most of them are actually tests of liver damage, not liver function. For the exam, the best way to approach this is to group them by the pathology they represent.
Okay, so group 1, tests of hepatocellular injury.
These are the enzymes that leak out when liver cells die, the transaminases, AST and ALT.
Which one is better, more specific?
ALT is more specific to the liver. A good way to remember it is L for liver. AST is also found in the heart, muscle, kidneys, even the brain. So if a patient runs a marathon or has a heart attack, their AST will go up. But their ALT should stay normal.
And how high is high? Does the number matter?
The magnitude matters immensely. In chronic disease, they might be just mildly elevated, say 100 to 300. But if you see levels greater than 1,000 IUL, you are looking at acute massive necrosis.
And what causes that kind of picture?
3 main things: acute viral hepatitis, a major toxin ingestion like a paracetamol overdose, or ischemic hepatitis, which is shock liver.
Okay, group 2, tests of cholestasis or obstruction.
Here we're looking at alkaline phosphatase, or ALP, and gamma-GT, GGT. ALP is found in the bile duct epithelium, so when bile flow is blocked, ALP rises.
But I remember ALP is also found in bones.
Correct. Bone, placenta, intestine. So if you have an isolated high ALP, the question is it the liver, or is it a bone fracture or Paget's disease?
And how do you tell the difference?
You check the GGT. GGT is much more specific to the biliary tree. So if the ALP is high and the GGT is also high, it's the liver. If the ALP is high but the GGT is normal, it's much more likely to be a bone issue.
Got it. Group 3, tests of excretory function.
That's really just bilirubin. You look at the total, the direct to conjugated, and the indirect or unconjugated fraction.
And finally, group 4, tests of synthetic function. You said these are the true function tests.
Yes. Albumin and the prothrombin time, or PTINR. This is the most important section for any anesthetist.
Differentiate them for us. Why have 2?
It all comes down to half-life. Albumin has a really long half-life, about 20 days. So if the liver stops working today, the albumin level won't really drop for weeks. A low albumin is a marker of chronic disease.
And the PTINR?
Factor 7 has a very, very short half-life, just 4 to 6 hours. So if liver takes a massive hit this morning, the INR will be elevated by this evening. The INR is the single best marker for acute liver dysfunction.
That is the take-home point right there. Albumin for chronic, INR for acute.
Absolutely. And you have to remember the direct anesthetic implication. An INR greater than 1.5 is generally considered a contraindication for neuraxial blockade. That's your spinals and epidurals, because of the risk of an epidural hematoma.
What about checking ammonia levels?
It's a special test. It can be useful in diagnosing hepatic encephalopathy, but it actually correlates pretty poorly with the grade or severity of the encephalopathy. It's more of a confirmation tool than something you'd use for monitoring day to day.
All right, Part E, interpretation and clinical correlation. Let's talk about patterns, putting it all together.
Yes, interpretation requires pattern recognition. It's not about one number. If you see a disproportionate rise in AST and ALT compared to ALP, you should be thinking of a hepatocellular pattern. The liver cells are dying.
And the opposite.
If you see a disproportionate rise in ALP and GGT compared to the AST and ALT, you should think of a cholestatic pattern. The plumbing is blocked somewhere.
And a mixed pattern.
Very common, especially in advanced disease or complex cases like sepsis where you have a bit of both going on.
Let's focus on the perioperative period. What does anesthesia itself do to the liver?
Well, as a general rule, general anesthesia usually reduces hepatic blood flow. This is mostly due to a decrease in cardiac output and systemic blood pressure that happens under GA.
And what about specific agents?
As we said before, halothane is basically contraindicated now. It reduces flow and inhibits that vital buffer response. Sevoflurane and desflurane are much better. They are vasodilators and are generally considered safer from a hepatic perspective.
What about regional anesthesia? Say I do a high spinal, a T4 level for a laparotomy.
So you get a sympathetic blockade. This drops the mean arterial pressure. And since portal flow is pressure dependent, the overall hepatic blood flow drops by about 20%. It's usually well tolerated in a healthy patient. But in someone with marginal liver function, it needs to be managed carefully with fluids and pressors.
And what about the surgery itself? Is that a bigger factor?
Oh, absolutely. The surgery is often far more traumatic to the liver than the anesthetic. Upper abdominal surgery involves traction, packing, retractors. This causes a reflex splanching vasoconstriction and just sheer physical compression. This can reduce liver blood flow by as much as 60%.
Okay, let's get really practical. Drug selection in a patient with abnormal LFTs. Let's start with muscle relaxants.
The gold standard here is either Atracurium or its isomer, Cystatricurium.
Why those two?
Hoffman elimination. They degrade spontaneously in the plasma, dependent only on pH and temperature. They do not need the liver or the kidneys to be cleared. They literally don't care if you have end-stage cirrhosis.
What about the common ones we use, like vecuronium or rocuronium?
They are steroidal compounds. They rely heavily on hepatic metabolism and biliary excretion. Rocuronium, for example, is largely excreted unchanged in the bile. If you use rocuronium in a patient with severe liver failure, the duration of action can be significantly prolonged. You absolutely must use a nerve stimulator to guide dosing and reversal.
Opioids.
Remifentanil is the safest by far. It's metabolized by nonspecific plasma esterases. The liver doesn't even touch it. Fentanyl is generally okay because its initial action is terminated by redistribution, but repeated doses will definitely accumulate.
And what about morphine?
I would avoid it if possible. Morphine has active metabolites, specifically morphine 6-glucuronide, that rely on renal excretion. Patients with liver disease often have impaired renal function as well, the so-called hepatorenal syndrome, so this active metabolite can build up and cause prolonged respiratory depression.
All right. Part FICU and exam integration. We need to talk about shock liver.
Ischemic hepatitis. You see this in the ICU after a cardiac arrest or a period of severe shock. It's classic zone 3 necrosis. What you see on the labs is a massive, rapid spike in AST, ALT, and LDH, often into the thousands or even tens of thousands.
Does it recover?
Surprisingly, yes, quite often. If you can restore perfusion to the liver, the enzymes tend to drop just as fast as they rose. It has a very characteristic spike and drop pattern over a few days.
And sepsis, how does that affect the liver?
Sepsis often causes what we call cholestasis of sepsis. You see a high bilirubin with relatively normal or only mildly elevated enzymes. It's thought to be due to inflammatory cytokines that essentially paralyze the bile pumps in the hepatocytes.
Okay, let's look at those Viva traps, a specific question. Can you do an epidural in a patient with elevated enzymes but a normal INR?
Okay, good one. Technically, yes. The elevated enzymes mean there is liver damage, but the normal INR means the function, specifically the synthesis of coagulation factors, is intact. So the risk of bleeding from the procedure is not increased by the enzymes alone.
But there's a catch.
Of course. The catch is, you must investigate the cause. If it's acute viral hepatitis, you might need to cancel the surgery for completely different reasons, but not strictly because of the epidural risk itself. It's a nuanced answer.
Here's another one, a classic trap. Your patient has a very low albumin. Is this acute liver failure?
Absolutely not. And you have to be firm with that answer. Albumin takes weeks to drop because of its long half-life. Low albumin means chronic disease or maybe severe malnutrition or something like nephrotic syndrome. It is never a sign of acute failure.
And in terms of presenting this information, what diagrams should the student practice drawing for the exam?
Don't just draw the hexagonal lobule. I see that all the time. Draw the liver acinus, draw that diamond shape, label your portal triad and central veins, and clearly mark zones 1, 2, and 3. Examiners love that because it shows you understand physiology. Also, be able to quickly sketch out the bilirubin metabolism flowchart.
We are nearing the end here. Let's do a summary. The 15-second recap for that last-minute revision before walking into the exam hall.
Okay, here it is.
Yeah.
The absolute must-knows. 1. Dual supply. Portal vein for volume, hepatic artery for oxygen, and the buffer.
2.
2. HABR. Port flow goes down, the artery dilates. The mechanism is adenosine washout.
3.
3. Zones. Zone 3 is perivinous. It has the CYP450 enzymes, and it's the most vulnerable to shock.
4.
4. LFTs. A stop for damage. INR and albumin for true function. INR is for acute, albumin is for chronic.
And 5 for anesthesia.
5. Anesthesia. Avoid halo-thin. Use this Atracurium. Monitor the patient's glucose. And always correct coagulopathy before you start.
That is absolutely brilliant. A perfect summary.
And maybe a final thought to leave you with. We have a dialysis for the kidneys, we have ventilators for the lungs, but we still have no true artificial liver. The synthetic, metabolic, and detoxifying complexity is just too high to replicate mechanically, so you have to respect the liver.
A great point. Visualize those hexagonal lobules and those flow gradients during your next revision session. Good luck with the exam.
Good luck.
Thanks for listening to The Deep Dive.